Hello, listeners, and everyone out there. This is Dr. David Spiro, your host at HUMED, Human Medicine, where we dissect stories from folks who are working in healthcare, because everyone has a story to tell that really relates us as human beings to each other. And today I'm incredibly honored to have Greg Adams with us, who I work with closely at Children's. Welcome to the show, Greg.
Thank you. It's a pleasure to be here.
And so, Greg, I would love to, for our audience, you are actually our first social worker and person in your role to be on the show, and hope to have many more folks who are all part of the team that do a great job in taking care of children. And I think for those listeners who are um, thinking about healthcare, it would be great to hear a little bit about your background and how you got to where you are today.
Yeah, thank you. Well, I went to college not knowing what I was going to do. I just wanted to make a difference in some sort or another, and I eventually discovered social work, and the more I learned about it, the more it seemed like it was a good fit for me. Um, so I did that, and then I went to graduate school. If you're going to be a social worker and have many choices in the world, you need to get a master's degree in social work. And so I did that, and then ended up coming to Arkansas. My wife is from Little Rock, and we got married, and I came here, and I worked in a residential treatment facility for 4 years with teenagers who had behavioral and emotional challenges. And after 4 years, I was ready for a change and had a psychology friend who worked here at Children's. And she encouraged me to consider this. And I really had never considered medical social work. But I came over and thought, well, I'll give that a try, and if they'll have me. And I remember my interview, they asked a kind of a typical interview question, which is a good one. They said, after we talked about the position, they said, well, what do you think would be one of the most challenging things about this kind of work? And I said, well, I've never really been around when people died. And so I think that would be a new thing for me. And I think I put that out into the universe, and the universe took that as an invitation to teach me, because I was here for just a few months, and I ended up transitioning over into the hematology oncology team, and I worked there for 10 years. And back then, there was the only social worker on that team.
Mm.
And I ended up still being in your part of the world some, in the ED. Sometimes we'd have our cancer patients come in, or back then we were on call about once a month from midnight to 8 in the morning to cover things in the hospital, and often it were abuse cases or psychiatric cases in the ED. We began and started a grief support program, doing grief support groups. Ended up helping to coordinate that, and we've done that for 30 years. And then part of my time here, we worked with the palliative care program and got that off the ground, and it's now a thriving program. I'm not part of that anymore. I helped in the early years, and I still do palliative care education, but I don't get the chance to do the
So you
direct
use the word
service.
palliative care. Can you explain to our audience, if they're not medical, what palliative care means?
Sure. Yeah, so palliative care is where we really try to help support families in the pediatric world, who have a child who has a serious and life-threatening condition, and we may or may not know what the outcomes are going to be for them, but we know it's going to be hard.
Mm-hmm.
And so we try to help work with that family as an additional source of support and guidance, so that we can help their life to be as good as it can be forever, however long it goes. And it may go for years, it may go for weeks, but we want to help them have good life and long life, and try to balance what that means for them. And it's an interdisciplinary team that works, alongside their primary teams.
Yeah, one of my mentors and friends back in Oregon, who's an adult physician, was explaining to me in palliative care and sort of in the world of adult end of life, it's not just about the quantity of your life, but the quality of your life. And
Yeah.
sometimes we get focused on the quantity especially in the cancer world, how long is my child got to live versus can my child live a high quality life during this time?
Yeah, I think that's a great point. I think our automatic response in healthcare, which is makes sense and it's appropriate, it's it's this to help somebody stay alive,
Yeah.
and we want to do that. And when they hit, if I was to collapse right now, I want that bias. I want you to help me stay alive. But but maybe there are some situations where that wouldn't be the thing, to do everything possible to keep me alive, because there's other considerations that are going on. And so I think when palliative care works really well, we're trying to take a couple steps back and think more deeply about the decisions that we make and what kind of consequences it could have.
Hmm. So, Greg, everyone has stories to tell or a story to tell in this crazy world of healthcare that we're in. And part of the show is about telling a story. And I've heard you speak before to our group in pediatric emergency medicine, and you're an incredible speaker and lecturer, and would love to hear a little bit about what story you'd like to bring with us today and share.
Thank you, David. It was such a nice invitation to think about, and trying to think about what story to focus on. And I kept coming back to this story. And so part of my job as a social worker and working with our grief support program is that sometimes I get calls from the community when there's been a death that impacted a family or a school, and they need some extra help. And so a little over 10 years ago, I got a call from a mom, and it was a Monday, and her son had killed himself the night before. And she had two sons, and the one son had killed herself. And they lived here locally in the Little Rock area, and she needed to talk about it. And so I did something really unusual. She just seemed like she was in such a vulnerable place that I didn't want to ask her to drive here to do it, and it felt like it needed more than a phone conversation. And so with her permission, I went to her house. And so I drove to her house, and her ex-husband, who was also involved in the situation, he came and met us there. And we talked. I was there probably a few hours. And we talked about their son and about what happened. We talked about their concerns about their other son and about ways what we know about suicide and what we don't know, and challenges of trying to understand those unanswered questions. So over the years, I ended up continuing to be connected to that family. There's a local family whose son had died by suicide, and they started a foundation, and they started for about 6 years, they did a camp for kids who had been impacted by suicide. And so I assisted with that camp, and I would go and hang out with them, and then we would do grief support activities during that camp. And this brother would come to that. And so I got to see him every year. And actually, the school where he attended asked me to come after that happened. They did like what a lot of schools do, where they had people in the library be able to come, kids come, be able to give each other support. And they wanted an extra person there to be there to talk with the kids. And, so I ended up going to that school. And over the years, we did some educational things here on our campus to try to help people understand about suicide. And both the dad and the mom separately were part of some panel discussions we did to help people understand about suicide. And this past fall, just a few months ago, we did a panel. We did a program for 30 years to mark our grief support groups, because they came to our grief support groups too, with the brother and the mom, and so he was able to be a part of one of our panels for people who had experienced a death during their childhood. So he's now in his mid-20s. He lives outside of Arkansas. And he just did a wonderful job, talking about that whole thing. And so that family has just continued to be, I think, part of my life in different ways. And because they've wanted to make some legacy of their experience, they have been open to sharing about their experience with other people who might need it. And just one other thing I would mention that it has really stayed with me. So when we had this camp, the last year we did it, we kind of understood that this probably might be the last year that the family who's sponsoring it was going to do it. And they were in a different place, and some of their family was moving out of state. And so, but we had some kids who came every year and some kids who would just come every now and then. And we had kind of 5 to 12 kids a year came. And so I remember the very last year, I asked particularly these kids who'd been there every year, including this brother, I said, when you think about your person, who died by suicide, I said, how much control do you think they had of that action? Do you think it was 100% their choice? They had total control about what happened? Do you think it was kind of 0%? They didn't really have any control or choice at all? Or you think it's somewhere in the middle? How do you look at it? And every one of them thought that it was somewhere in the middle. That their person, did have some agency, did make some decision, but that they were taken over in some ways, by the emotion and the despair of the moment that they were in, and where that it wasn't, they didn't feel like it was totally within all of their control. And I thought that was such a wise insight that they could see it that way, that it wasn't just one or the other, but there was some mixture, in the middle there. And they just impressed the heck out of me. And this family has impressed the heck out of me. I still, because Little Rock and Central Arkansas is not that big of a place, I still run into them sometimes, socially or otherwise, and see them. And they're always very kind and open, and I think they're doing okay.
That's great. And they're lucky to have you in their life and your support. I want to take us back to the day that you went over to their house. And I want to quickly talk, because I resonate with being involved with families who are experiencing acute trauma and acute crisis from the loss or bad news of one form or another. And what was going on in the house that day, and what were you able to offer as a source of support to help this family manage their grief?
Yeah. When I got there, I don't think I had a great plan for what that was going to be like. I think I was trying to be open to whatever they might need at that point, and had some thoughts running in my head as possible things that we might touch on at some point, but I didn't want it to be my own agenda, and to impose upon them. I wanted to listen and try to see what kind of where they were and what the biggest concerns that they had. And I think a big part of the value of that was this was a brand new experience for them. It really was in like a strange country. And although I'd not been in their shoes as parents, I had been around other families who've been in their shoes. And I think to be able to listen and invite them to share about what this experience was like for them, and what some of the questions that they had, what some of the concerns that they had, that I wanted to be able to do that And I had a personal experience in that it was different, but it was related. So my father-in-law had died by suicide after my wife and I were married a year and a half. We'd moved back to Little Rock, and I was not yet working at the hospital. And it was a really shock. We didn't see it coming. Looking back, the family who knew him best could see signs, but they didn't see it at the time. And I remember that feeling of helplessness. And like, I am so over my head as a young husband and family member. Like, I don't know what to do. And the helplessness of seeing, the person that I loved suffer in a way that I could not do much about. And I think that experience ended up being useful to me, in this experience.
It's interesting you say that, because I think as part of the human experience that we have as being healthcare, more than what I thought I would, I oftentimes draw on personal experiences to support families. I had an interesting experience the other day. I had a child that came in who was in remission for cancer and came in for an issue that was somewhat related, but not really. And I hadn't seen the dad in a couple of years, but we had bonded, and I remembered him, and he remembered me, and he said, "You have 3 boys, don't you?" And I said, "Yes." He said, "Well, I have 3 boys too." And I must have shared something with him about my family, and it was very useful to be able to share some of that and bring some of my experiences in. And I continue to do that as a dad, and who raised 3 boys from baby to adulthood. And I think it would be a disservice if we didn't, harness a lot of our experience to bring that to support families. What do you think?
Yeah, I think so too. I know when I have a chance to talk to social work students, and I teach a class on grief and loss at the local university graduate school for social workers, and we talk about that, about how do you use your own experience and in a way that's helpful and fitting. And I really think that there's a place for that if we're very thoughtful about it. It wouldn't be one of those things where I would say that you would always share it with everybody in any situation, or you'd never share it. It'd be somewhere in the middle, figuring out, if I share this, could it be helpful to this person to feel not as alone and to feel better understood? Because I think, and this happens in pediatrics a lot, when people look at their doctor or their nurse or somebody and they say, "Do you have any kids?" And we have a lot of young professionals on our campus who don't have kids. And I think that's okay for them to not have to say, "Yes, I don't have kids, but I have nieces and nephews." That I don't think that's the point. I think the point is, this is my family. Because if somebody asked me, I would say, "Yeah, I do. But, I've never been in your situation."
Yeah.
So what's it like to be a parent in your situation? And I think what their families are looking for is, are you going to judge me? Do you have a clue? And are you going to judge me? And I think if we can let them know that we want to we want to understand, and we're not going to judge them, and we can turn it back to them, even if we share, which I think can really be powerful, that, yeah, I'm a dad too. And, my son's been in the ED, and my son's been admitted and has a chronic disease. He has type 1 diabetes, and that impacted me about now how I work with other people, because I remember that I know what it's like a little for me. I can't know what it's like for them, but I know what it's like for me to have a son and a child with a serious illness, and that's going to have to be managed. So it gives me just a little clue, but it doesn't give me the whole picture, but it just gives me a little peek in the window, I think.
Well, I've always thought well, if we look at the history of medicine, 200 years ago, 150 years ago, physicians did not have offices. Physicians went to the home
Hmm.
to care for patients and would deliver babies in folks' homes and come to support a family with whatever they were needed. And it's only been in the last 100 years where we've had hospitals and we manage most medical things now in hospitals. But I've always thought that you learn a lot from a family when you get to go into their home. And the reason why I can draw on that experience, and I really appreciate you bringing this story, is before I became an ER physician, I was a primary care physician, pediatrician in a rural town. And when babies were born, I did the first visit at the house. And I came out with a scale and a doctor's bag and did all the things I needed to do. And it was an incredible bonding experience between myself and the family. And then, most of the visits afterwards were back in the office. But I remember fondly going into the home and sitting there for an hour or two. It's not just about the baby, it's about the family and the extended family, and everyone wanted to see the doctor who's coming in and weighing the baby and sitting down and talking about it. And one of the themes of this show has been what really, and we may not get a full answer to this, is what is medicine really? What is this practice of medicine that we're all doing, from your end, from my end?
Mm-hmm.
And I think the true practice of medicine is the connection we have as human beings to our patients. It's not about prescribing Augmentin or recognizing this or that. I mean, yes, that's part of it. But I think, for me at least, the meaningful part of what I do is that connection. And so in the moment, what inspired you to go into the home? Was it an instinct that you said, you know what, I'm not going to conduct an interview in the hospital or wherever I am. I'm going to try to invite myself and offer myself to come to the family home. And what inspired you to do that in the moment?
It's a good question. I think part of it was that there was nothing that I had here at the hospital that we that couldn't happen at their home. There wasn't any kind of material or equipment or anything that would mean that connection had to happen here. And it just felt too much to ask her to navigate to come here. That mom was in such a vulnerable position and was reaching for help, which was a gutsy thing to do, right? To call somebody who you'd never met before and say, this terrible thing has happened and I'm not sure what to do. And so it felt like that what I could do was to try to meet her there, but to meet her at that position where she felt the most comfortable and not add to her vulnerability. I think if I said, well, could you come up here? I think there's a good chance she would have said, I don't think I can, or not today. And we would have missed the opportunity. And when you mentioned that about going to the home, the thought that came to me was about, it's a real humility to go to somebody's home. When they come here, they're on our turf, right? They're in our system, and it's their job in some ways to adjust to us. But when you go to somebody's home, it's our job to fit in and adjust to them. And so that's really a different kind of experience.
Yeah. Well, for those who are younger or older in healthcare and not in healthcare, when you've been around so much support and around death and dying in those kind of scenarios, what are common ways and methods that you use to support families in a time of hearing bad news.
Yeah. You know, I think in some ways that whenever we enter into an encounter with a family around a high stakes issue, like their own health or their child's health, we follow a similar kind of a pattern. We establish some rapport in the beginning, and sometimes that can look like to as an observer like we're just chit-chatting, but it's much more intentional than that. It's like I'm wanting to make a human connection and help that person to feel comfortable. And if that means talking about, the football team that's on their t-shirt, or you know, what kind of things their kids likes to do, and oh, he plays soccer. Oh, my kids play soccer. What kind of, what do you do? It's talk, but it's then being able to establish that rapport and then transition into inviting their story. What has brought them to this moment, and if it's somebody we know, we're doing like, what's happened since the last time I saw you, and that's the story. And if it's somebody we know, we might do that rapport thing super fast because we're good at it, and because we've already established a track record with them. But oftentimes it's still that social connection of the little rapport, and then inviting the story, trying to understand what are the things that are really important to them at this point, and letting them know that we are going to be helpful, or do the best we can to be helpful. And I do think that I've been so impressed over the years, whether it's talking to patients and families or talking to healthcare providers, which I get the privilege to do, that if people can feel safe and supported, they are often willing to talk about incredibly hard things.
Yeah, I appreciate that.
And
I really appreciate that.
Yeah, so anything I can do that helps them know that they're safe with me, and that they have my support and not judgment, then we can kind of go and try to figure out what's going to be helpful to them in this spot. And I love what you said about what healthcare is about. And when you said that, I thought the first thing that came to my head was, well, healthcare is about wholeness. It feels like it's about helping somebody to be as whole and healthy as they can be in themselves in the situation. But
it's funny that you said two things that I think were really sage. One is getting to a point where there's something you can bond or connect with a family, and it could be anything, and sort of learn. But then also the other sage thing that I learned today is sort of creating a space that feels comfortable for them to tell their story, and which is part of what the show's all about, which is telling a story and learning from it, and holding space for us to learn from Greg Adams today about how you approach grieving families, etc. I had a very unusual first-time experience in the last couple weeks where I had to give bad news to a family, and I gave it twice because the mother was there, and then the father came later, and everyone wanted me to speak to the dad because he was pretty distraught. And it was interesting. In the room, I was with the social worker, I was with the chaplain, I was with the mother, I was with the father, and the two grandfathers on each side of the family, which is unusual. Usually it's grandmothers or grandmothers and grandfathers, but not a grandfather. And I had two grandfathers there, and they were doing an incredible job at supporting their kids in the moment. But what happened really took me by surprise, because it became clear to me, because learning from you and what you do, is I asked some questions about the family and what do they do. And one of the grandfathers was a minister at a local church, And they were from a small town in Arkansas, which many of our families are from. And he said, and it was clear that he had some skills in support. And so when I was wrapping up the second time I gave bad news with the father in the room, I said, listen, I know that you're a minister, and I'm going to pray for you all. And, they really were taken aback by that statement. And I said, is there anything else that I can do for you? And they said to me, um, will you pray with us? And I said I would love to. And, you know, uh, my audience knows that you're not listening for the first time, or if you are, is I'm Jewish, and I'm not from these parts. But Jews pray, and Muslims pray, and Christians pray, and people who are atheists pray, and the chaplain who was in the room did a beautiful job, and with the grandfather, in leading a prayer, and we all held hands, and it was an incredibly touching and human experience that I had.
Yeah.
And I'm imagining also, in your line of work, you just don't know what's going to happen, and you have to roll with how the family is receiving and processing, and you kind of almost have to be adaptable in the moment, because there's not one size fits all way to support a family. Is that fair?
I think that's very fair. And I think that that is it's such a practice, because we don't always, I don't always get it right or do the best job, and sometimes, but I've gotten better, and I hope to continue to get better at being able to read the cues and communicate what I want to communicate. And but I find that there's such a generosity for most people, that if they sense that you are trying to connect to them, and that you have compassion about them and their situation, that they give you a lot of space. Most people, I think. And one of the things that I feel like that I have continued to learn, and it's not something to master, but is to become more comfortable not being able to be helpful. So to be more comfortable being helpless.
As a supporter, as someone that's supporting the family.
So when I went to that woman's house, there was no way in the world that I was going to touch the depth of her pain and take any of it away. That was impossible. And so my job was to try to be as present as I could with that pain, and not be anxious for the fact that I could not take it away. And I think about that in the role that you and my physician colleagues do. You and your teams can do remarkable things sometimes to rescue people from their situations, which is a great blessing, and I'm sure glad that it's there. But that's generally not what haunts us or challenges. It's the stuff that we don't get to do. That's beyond our capability of influence or of helping. But I think that the more that we're comfortable with what we can't do, the more we're comfortable with the helpless, then the paradox is the more help we're able to have, because we're not adding our own anxiety of having to be helpful to the anxiety of the situation, which is already enough.
Well, I really resonate with that. That's also incredibly sage. I think that as I continue to develop the show, and continue to progress towards the latter third of my clinical career, I've become more comfortable being helpless, and I've realized that even in the world of emergency medicine, where we fix fractures and we do some good, there are many times we see families that we're not helping them, we're not hurting them. It's just they're there. And, anytime there's a medical treatment plan that's discussed in there are three outcomes. Children get better, children stay the same, children get worse. And
Uh-huh.
sometimes children get better despite what we do. But what I continue to what continues to drive my interest in the work that I do is the relationships I have with the children and the
Yeah.
families, and understanding that we are helpless in much of what we're trying to do, and we continue to try to be helpful because it's all the reasons why we go into this work. But accepting helplessness is sage
Yeah.
advice.
Well, thank you. I think that's been something that's really come back to me a lot. I think that in some ways it helps us with that relationship, because I so connect with your thoughts on with a relationship. It's hard to do much of anything good without a relationship, and but part of the relationship sometimes is we join people because we join them in that fear and in that helpless, of course, because they feel that.
Yeah.
Like, this is bigger than me and everything's out of control. And sometimes we're joining them to say, well, yes, it is. But these are things we can do. And sometimes it's like, yes, it is. And you're not alone in it. We're in it with you.
Yeah.
And that may be as big a thing as we can do in that particular moment, is to let them know that we're going to join with them.
Yeah. Well, if you had to summarize our talk today, and for our listeners to take something away that is truly meaningful, what would it be?
Hmm. I keep coming back in my work, David, to the idea, and it shows in this particular family too, but is that life can be much harder for some people than I think I ever understood or imagined. That they have to deal with such difficult, painful situations. And it doesn't seem like it's equally distributed. Some people get way more than their share. But that life and I knew that in my head, but I didn't know it in my gut and in my experience. And I've learned more about it with that. But the other side of it is that people can find ways to survive and even thrive despite terrible situations. And that the terrible situation is not the end of the story. And I think about this particular family, who will always carry an amount of heartbreak, in their lives.
Hmm.
But that is not the whole of their lives. There's other parts of their lives too, other parts that they could not have imagined on that day when I went to their house.
Hmm.
That how rich their life could be, while the heartbreak is still present.
Well, I think there are probably many topics that we can discuss, and I would love to have you back on the show if
Oh, thank you.
you would be here. And I'll just say on a very personal level, you're an incredible human being, Greg Adams, and
Oh, thank you.
Arkansas Children's is so lucky to have had you in the role that you're in, and all the families that you've served are lucky to have you in supporting them, and also how you support our medical team as well, and coming to our retreat in pediatric emergency medicine this year and offering your perspectives on approach and things of this nature. It's always refreshing. It's always delightful. And it's also emblematic of the fact that not one person can do everything. We are one team, as
Yeah.
Arkansas Children says, is really true. We're
Mm-hmm.
one team anywhere you work, and we're all working together to support the health of children, at least in the world of pediatrics. So Thank you for being an awesome colleague. Thank you for being on the show, and looking forward to further discussions. This is Dr. David Spiro, your host at HUMED, and please subscribe on YouTube, Spotify, Apple Podcasts, wherever you digest this show. And I hope you all have an amazing rest of the day.
Thanks for listening to HUMED with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.